To take a look at how Nigeria can build its testing capacity, we're being joined via Skype by Dr. Casmir, Publicity Secretary, Association of Medical Lab Scientists of Nigeria. Thank you, Dr. Casmir, for joining us.
Yeah, thank you very much.
And how are you doing this morning, Doctor?
I'm cool. I am somewhere in a suburb area in the FCT.
How would you assess the COVID-19 testing capacity in Nigeria compared to its population?
Well, the testing capacity, I can tell you we are doing not very pretty good, because we have capacity for more than what we are currently doing. And unfortunately, it is because we are engaging wrongly. The tests we're doing is such that we have adopted the one as approved by the WHO, which is a molecular-based testing. And we are doing that. But when we started out, we had barely 5 laboratories with capacity to provide testing in that regard. And as of today, we have about 22 laboratories with capacity in that respect. Unfortunately, we are underutilizing the capacity because we have only done about 22,000 tests in the last 3 months. Up until April, early April, it was just below 6,000. And as at now, it is 22,000. What that has shown is that our number of labs have increased, but the capacity utilization of the labs are still very low. And for instance, on the 5th of May, the data put out by NCDC showed that they could only process 1,698 samples, meaning less than 2,000 per day. Whereas they have now activated, according to Dr. Chukwuekazo, the DGen CDC, they have activated the Roche Covas testing machine that its daily throughput is about 5,000. So why are we still trailing behind? And in places like Lagos, we yet have backlog of unprocessed samples. As at 48 hours ago, in Lagos, we had well over 2,500 samples unprocessed. And several states have sent samples and they are yet to get results. Sometimes it takes a lag of more than 7 days, even trailing almost into a fortnight, before results for samples submitted become available. That is not a very good performance. Honestly, smaller countries are doing a lot better. Even though when you say that, the DGen CDC will interject that he's not into a game of numbers. And he need to be told straight that indeed we're into a game of numbers. We pride ourselves as having a population of well over 200 million. And so if we have a population of well over 200 million and we have the enormous resources available to us in this country, we should do a whole lot more than what we're doing presently. So I am personally not satisfied that we're still trailing behind in testing. And the reason I'm not satisfied is that I continue to insist that we have enormous human resource. It is not rocket science to deploy real-time PCR to test for COVID-19. It is not rocket science to deploy the Covas SARS-CoV-2 testing approved by the WHO for testing. So I am really worried. What is the disconnect? The disconnect is that we're very frugal with our approach, with our recruitment, with human resource engagement to ramp up testing.
Now, Dr.
We
Casmir,
can do 247.
Dr. Casmir,
yes.
Yeah, a few days ago,
yes,
there was a report on the shortage of reagents and other important materials needed in tackling a health emergency like COVID-19. What do you think brought about this kind of development?
Yeah, that is understood because there's a heightened global demand for the testing kits. It's not only our laboratories in Nigeria that have need of the kits, but it simply means that we have a very frail, weak, non-existent logistics supply chain system. If we had a robust logistics supply chain system, we will not got stock and got stock out. Because how many test units did you order ab initio? And if you do that, as you continue to deplete your stock, an expertise in logistic chain and stocking would know when to place order. You do not place order when you run out of the items. That is the wrong time to place an order, because when you get to a mean volume in your stock, you place order, particularly when you know that there's a heightened demand for that particular product.
All right, Doctor.
Besides, what are we doing?
Yeah.
Yes?
Just finish your thought. Finish your thought there, please.
What are we doing at beaming the satellite on in-country capacity for producing some of these items so we do not run cap in hand?
Right.
I'll give you an example, a ready one for that matter. Japan developed what we call in-house keeping protocol for testing for COVID. All they made sure was that it was a molecular-based testing technology that they deployed, what we call nucleic acid amplification technology, NAT. And I want to also tell you that we are working as a professional group, and as I speak with you now, we have come up with what can be a stopgap measure. In every state of Nigeria, we have the traditional thermocycler, and we have gone ahead to develop a protocol that can enable us to deploy this. It's also a molecular technique.
All right. Now, Doctor, shouldn't there be a move to consider homegrown solutions, like you were rightly pointing out when you were speaking earlier, and investing in local production of these reagents and other materials?
Yeah, that is what we're saying. Yeah. Now, the PTF COVID continue to meet. Let me tell you, the clinical conversation around COVID must cease. What the conversation that should be had and heightened is the conversation of going through our population to say those who have it and those who do not have. For those who have, you now commence the clinical conversation around them. That is what we have not done.